when it comes to hospice massage and being able to shift from the office to the home. I think probably you two may be quite the experts on it. It's kind of a big deal to shift from working with people that are not even metastatic to working with people that are in hospice. That's a huge jump. And I really appreciate Cindy Spence and Susan Gee being here today to share with us, because this is something that I think all of us will also be able to learn from and share and help support more and more people, which is the point of S4OM. Well, Susan, Cindy, please go right ahead.
First, we want to thank you, Zerlin and Ashley, too, for this lovely invitation to be with you guys. We're truly delighted. Susan and I met at the 2013 Oncology Massage Summit, or S4OM, in Minneapolis. We both lived in Dallas at the time, but we had to go all the way to the S4OM conference to meet. So we have a lot of fondness for this group and all of the people in it. And we especially appreciate those of you who are devoting your time, your energy, your talent to these leadership positions. Just so important. So thank you for everything that you're doing to move our work forward. In 2016, with some gentle nudging from Gail McDonald, Susan and I formed Final Touch Training to bring quality education and resources to massage therapists working in end of life care. And let's just be truthful, that's all massage therapists. We are all working in end of life care because everyone is going to die eventually. And so we feel like these are skills that all of us need to know. We will all have clients, we will all have loved ones, and we just feel like the topic's important to every human being. What we realized early on in our careers is that the end of life is frightening for many people. And because of that fear, many people, when they need touch the most, are not being touched. And so we're dedicated to supporting all of you who are in the position to provide safe, powerful comfort at the end of life. And, one thing that happens at the end of life across this care continuum is that people lose their ability to leave their homes. And that can happen permanently at the end of life when someone is homebound, but it also can happen for someone who has had a debilitating surgery or a treatment that confines them to home, at least temporarily. And so we really would like for everyone to get comfortable with this idea of providing care across the continuum. So we're going to talk today about the home scenario, how to adapt what you do for the home setting. And we'll look at some photos, we'll share some tips, things that have been helpful to us, but we really want this time to be what you need it to be. We're a small group. We love questions. So just let's keep things informal. If you just wave and get our attention, we're happy for you to jump in and take things in whatever direction would be most helpful to you all. Is everybody looking at what I'm looking at? So we thought we would start with what we all learned in massage school. Does this look kind of like a scenario that you all learned in massage school? So we have a client, she's lying supine on a table, a massage table. We have a bolster under her knees, kind of a one size fits all approach. These bolsters tend to be made of foam. They're usually very hard, not very soft or forgiving. Did any of you learn to put anything under the head? Just say yes or no.
Yes.
Yeah, you did. So I didn't learn to put much under the head. And if I go for a massage now, invariably the therapist will pull the round cushion off of the face cradle cover and kind of want to put it under my head, which I personally don't find comfortable. So this is kind of what the extent of what I was taught in 1999. Now, when I asked this client, "How does this feel to you?" she said, "This is great." So she was satisfied with this until I provided her with an option of something better. So, those of you already in oncology massage work may have already upgraded to a scenario more like this, where we have introduced some soft materials. We have filled in all of the curves and the contours of the body so that every surface of the body has something to rest on. We've brought the surface of the table up to meet and cradle and hold the body. Now, when I asked the client how she felt about this compared to the other one, what's your guess? What was her feedback? She said,
That
now
looks yeah, much more comfortable.
She said, "Now this is really great." I don't think she knew she wasn't quite comfortable until she got to this. We could take this scenario that you're looking at, the bottom slide, and we could literally transport this scenario into the home environment. This is a portable table. I could carry this table in. I could carry all of these materials in with me, but I never do that. I don't think Susan ever does that. So why not? Let's talk a minute about why we don't carry a portable massage table with us. So the first thing, just in a realistic practical sense, is space. Most people have very crowded conditions in their home anyway, and then you start bringing hospice equipment into the home. People may have an oxygen generator, they may have a wheelchair, they may have a walker, they may have a portable commode beside the bed. There's just not space typically to set up a massage table. Second is the issue of infection control. If you carry a portable table and all of your materials with you from client to client, you can see that you're creating a scenario where you may be jeopardizing your clients. Another safety concern is that many people, due to debilitating illness or medication, grow weak and become a fall risk. And so you've got a person who's trying to climb on and off of your table. You have a person who may be trying to reposition mid-session. All of that creates safety risks for the client. Many people can't lie prone anyway with advanced disease. Either they have breathing issues, they may have medical devices, they may have surgical incisions, they may have ascites, swelling of the abdomen, so laying in a face down position is not going to be comfortable for them. But finally, many people fall asleep during their massage, right? And so, what does that mean if you've taken your table and all of these nice cushioning materials in and a person falls asleep? You have to pull all of that out from under the person once they've fallen asleep. We find that it's much easier to provide a massage where a person feels most comfortable sleeping. So, in our time together, we'll focus on massage in a regular bed, how we get the client comfortable, how we get ourselves comfortable. We'll share some tips we've learned, sometimes the hard way, from our many years of practice.
Okay, well, I'm going to show you guys some pictures. You know, they say pictures are worth 1,000 words, so we'll just start there and look at how we can get clients comfortable in a regular bed. But before we go there, I'd like to talk a little bit about getting ourselves comfortable. And in this particular picture, you can see that there's no space for a massage table. My patient was in a hospital bed, and her spouse slept in the bed behind me. And here I am sitting on a stool that we'll give you some details about in just a minute. And as I think about my own body mechanics in this picture, they're really not too bad. I'm not leaning and I'm not twisting. And so I try to be very mindful of my own body mechanics in a home environment to keep my own body safe. So this is a stool that I was sitting on, and they are available at Massage Warehouse. Currently, they're about $68. They fold up really nicely. They go fold up flat. And before I take this stool into my next client's home, I always wipe it down with a Clorox or Lysol wipe to keep it sanitized. And this is the picture that Cindy showed us of our client on the massage table with all of the props and positioning items. And I just want to show you how we can duplicate that same positioning in a home environment. And this is Valerie. And if you'll notice, her headboard and side tables are large and heavy. So we really couldn't move those out of the way. So we invited her to come to the end of her bed, and she's laying sideways across her king size bed. So you have access here to the head, the entire side of the body, and the feet. And I would use my stool in all of those positions, just moving it as I go. And if Valerie was able, we could ask her to turn mid-session so that we could reach the other side of the body. But what we've learned in end-of-life massage is that our massages are often not symmetrical, and we have to be happy with what we can reach. And this is Judy. Judy had a really tall bed. So we've asked her to move. So now she has her head at the foot of the bed. And I'm standing and have great access to her shoulders, her neck, her head. And I can even support my own arms on her pillow. And now I'm just moving down the side of the bed. I can reach her arms and hands in this position, and you can see the pillow under her knees and another pillow under her feet as we provide massage there. And again, if Judy was able, we could ask her to turn so that we could reach the other side of the body. In this picture, I'd like for you to notice the left picture has a pillow horizontally placed under the legs, and the one on the right has two pillows placed vertically under each leg. And we have learned that clients prefer the two pillows vertically. So you might want to try each way with your client and see which one they might prefer. And this is Patricia. She had a low bed. Cindy is sitting on her stool. You can see here that one side of the bed is pushed against the wall. And also the end of the bed is pushed against the wall that you'll see in the next photo. But sometimes, again, we just don't have access to the full body. But we can provide great massage here to the shoulders, the neck, the head. And again, there's support for the arms, for Cindy's arms as she's working.
Her head again is at the foot of the bed. We've had her turn.
Yes, thank you. And now as we look at side lying, this is Judy again. So please note the folded towel under her head. We've placed a pillow between her knees, and she had this rolled pillow there in her home that we placed between the ankles. And what you can't see in this picture is that she has a pillow under her top arm, which provides some balance and support. But here I have full access to the backside of the body. And here's another picture of her in the side lying position. And what I'd like to note here is how I'm leaning. And I wish now that I would have asked Judy to move closer to me and closer to the edge of the bed before we got all of the propping in place, which would eliminate me leaning. So we learn from our mistakes, right? So here we have good access to the back side of the body and the hips. And this sees the pillow. You can see the pillow under the arm there, the top arm. Access to the legs. And this is, again, is Patricia in a side-lying position, but you'll notice that she's facing Cindy. So here the client is facing you. And what we're doing is reaching over the body and pulling the strokes toward us, which really feels really good. And Cindy is sitting on her stool there. Oh, another thing I'd like to point out is that a lot of the massage we do at the end of life is over clothing. So just make note of that. However, we do have clients who prefer to disrobe. As you can see in this slide, you just want to remember to keep the body covered for warmth and modesty. Another thing to point out here is the rolled washcloth under the neck, which is just filling in space there. So any questions about any of these pictures? Anything you want to see again or can move on? Okay, I'm going to
I
stop.
have a quick question.
Sure.
Some of my clients in the past who are hospice have asked me to actually get on the bed with them. What do you feel about that?
Well, I guess it depends on their state, how fragile they might be. Is it getting on the bed for access or
Yes.
getting on the bed for access? I have done it before, and I know Cindy has, which I'll let her talk about that as well. I've done it before, but it's not a common practice for me. I prefer not to get on the bed. Yeah, Cindy, I know. Why don't you add there?
Well, I was just going to say that Irene Smith was a fan of sitting on the client's bed. I think she found that a very comfortable way to work. And I will do it, but I typically will lay down. Do you guys know what Chuck's pads are? Those are those waterproof pads that tend to be in hospice environments, but you could just as easily use a towel or a small blanket from the home. I will typically lay that down kind of as a barrier before I put my body in the bed. And I think part of that just feels like it's just a good psychological boundary, but I think it also has to do with infection control, that once you've climbed into a person's bed with your clothes on, if you don't have some kind of separation, that then you become a vector. But Cheryl, how have you decided to handle
Yeah,
that
I'm curious
request?
too.
Yeah, it just depended on the situation, and a lot of my clients had mobility issues, and sometimes they were, for some reason, when I got there in the middle of the bed, and they weren't going to move or be able to be moved without considerable pain, and so I just adapted where I had to, and I would usually either put one knee on and lean over, not great body mechanics, and then I always took a change of clothes with me to deal with the infection prevention piece, because if I did go to another client's house, I'd want another set of clothing. But I just wonder, because some people have a real negative response about that, and I just wonder what your experience was. I had really good experience with it. I've had several MS patients who really responded well to that. They just couldn't move without a lift and some other stuff, and they were in the middle of the bed for whatever reason, and I just adapted to it.
Mhm.
I think that's perfect. It's a beautiful
Yeah.
solution. And I think Susan and I would both say, and anyone who's done this work would say, that the boundaries that you learn in massage school, that, might be a long list of things, a lot of those don't apply, in these sensitive, unpredictable situations that sometimes can be very humorous. Just have to really adapt and be open to creating scenarios that are going to be most helpful for your client,
And
so long as they're comfortable for you.
that's what I was going
Yeah.
to say. As long as you're comfortable doing it, then
I was going to say, when I've done it, and I've done it, it happens, okay? Not very often, but I made sure if there was another person in the home or caregiver that they understood what I was doing, number one, and that I had informed consent. That was like a really big deal for me. The other thing is, I really was very afraid the first time this happened. And I think Cheryl can attest. Sometimes there's just no way around it
Mhm.
because I was afraid I was going to bounce them out of the bed. I had the barrier, so I had already thought, but I was concerned that I was going to bounce them out of the bed. And so I had the caregiver come in and stand there while I got there and everything. The other thing is, one time I was working with someone and I wasn't even on the bed, but everything that they had said before told me they were not moving. They couldn't move. And as I was finishing and I turned around just a second, all of a sudden their legs came up. They felt fine. They were going to go to the bathroom. I was attached. Yeah. But I loved seeing the smile, I think, was on Patricia's face.
Yes.
That that was just really beautiful.
Yes.
One thing I'll say real quickly to piggyback onto Cheryl's comment is that you said it wasn't great body mechanics for you. It's just to always be aware, okay, in this moment, I'm not comfortable. So I'm going to do what I need to do and I'm going to move on. I'm not going to stay in this position for 1 second longer than I have to. So I hope you're taking good care of your back in those scenarios.
Thank you.
Okay, Cindy, I'm turning it back over to you.
Okay. So we're going to talk about travel kits. You guys know that adage about you put on your own oxygen mask first, right? So, in terms of what we carry with us, I want to encourage you all to carry some things for yourself. Every hospice client receives upon admission what we call a comfort kit. And a comfort kit is a supply of emergency medicines that are used in a crisis to make a person more comfortable. Well, we can make a comfort kit for ourselves. This is something that you can carry with you. If you're doing mobile massage, you can carry it in the glove box of your car. That's where I had mine. If you're stationary, you can have one in your studio, your desk drawer. This is your comfort kit is a place to go for the emotional fallout that we can all feel while we are working with these very beautiful but sometimes demanding and tragic and it's the whole catastrophe. So I encourage you to select some items that would be of comfort to you in those moments. My comfort kit has some frankincense essential oil. This is not a grocery store brand. I bought the really good stuff for myself because we're all worth it. I have a little angel statue that just fits perfectly in the palm of my hand that I can hold and take a few deep breaths. I have a beautiful string of mala beads that actually Susan gave to me. And mala beads have 108 beads on them. And if I hold each bead and I take an inhalation and an exhalation, it takes me about 10 minutes to get around the chain of beads. And that's a perfect amount of time to settle your nervous system. You know, if we're going to be a calming influence on the nervous systems of the people we serve, we have to settle our own nervous systems. And I just find this to be a great tool. Underneath the mala beads, I have one of my dad's cloth handkerchiefs. I lost my dad 2 years ago. And I try to call on my dad to always be with me and to help me know what to do, know what to say, just know how to be present. And I've recently started adding these little affirmation cards to my bag. Of course, you can tailor these to any saying, any thoughts, anything on paper that's a comfort to you. So pay some attention to your own comfort and what you might take with you that would be helpful to you. In hospice care, we refer to car stock, and that refers to the items that we carry with us. I keep mine in a big tin in the back of my car. So you can see there I have masks, I have lotion, I've got reading glasses. This is an old slide. I've now replaced the vinyl gloves that I have there. I would never use a vinyl glove now. I really, really like nitrile gloves that are much thinner, more pliable, much more comfortable to do massage with. I've also replaced the Febreze. I've found a product that I like a lot better. Myers makes a dryer sheet that's lemon scented. And if you go into a home environment where there's an odor that you don't want to carry with you to the next home environment, you can just take a dryer sheet, just kind of pat yourself all over with it. I have some liquid hand soap. I have hand sanitizer, a couple of topical analgesics. I take the lint roller because you're going to encounter pets in home environments, and some of them are very friendly. And I wear a lot of black, and I don't want to carry the pet with me into the next home. So I roller myself off. I have some nail clippers there, essential oils, disinfecting wipes. And then you'll see the little container down in the bottom corner. That's actually from a restaurant supply company, a little condiment cup with a lid. It's 1 ounce single serving size. That's what we actually put our lotion into so that we don't have to carry our lotion container from environment to environment. What I carry in with me is actually very minimal. I mean, you can see it's just a few things. I carry that individual serving size of lotion. I carry a pair of gloves. I carry scissors with me because I've noticed that these rubber bracelets have become so powerful. A lot of people have them for Live Strong and various cancers, but I've noticed sometimes at the end of life when people get extreme swelling, those start to cut into the skin and they need to be removed. And so I carry scissors with me if I see something like that. That little green thing that you see in my hand is actually an aroma patch. We can talk about those if anybody's curious, but I usually have one of those with me. Got the antiseptic gel and again, my reading glasses. In this case, I actually used the scissors in my hand to cut one of the gloves off of the nitrile glove because I had a little nick on a finger. So I made a finger cut right there on the spot by cutting one of the fingers off. I carry so little because I don't like to set things down. You know, again, this idea of carrying things from one client environment to another. So, in an effort not to set things down, things need to fit in a pocket. If I don't have a pocket in what I'm wearing, oh, can you all see this?
Mhm.
Yep.
This is called a hip clip. It's got little clips that clip onto your pants, and it's a built in pocket. Love those. And then last year, I found this travel scarf. This is an infinity scarf that has a little zipper. And so you can put your things inside the zipper and then just put your scarf on. So we're always discovering new things, that just help make life easier. Susan, I think that may be all I have.
Okay. Well, we wanted to show you the client intake form that we use. Zerlin's going to bring it up, and it's a very simple form that provides the basic information that you would need to know prior to going into a home environment and seeing a client at the end of life. It's likely much less informative than maybe some of your oncology intake forms because we're not as so much interested in folks being in treatment and that sort of thing. But we are providing this. You're welcome to download it, use it as it is, or adapt it for your own needs. So, are there any questions that we can answer for you guys?
or comments.
Yeah,
No,
yeah.
some of you are already doing this work and doing great work. We'd love to hear from anyone.
Do you have any resources that you use after the session for professional advocacy for therapists?
I'm sorry, can you say more?
Yeah, so end of life care can have acute impact on the nervous system of the therapist. And I'm just wondering if there's any triage or professional advocacy that can be implemented for therapists to begin the process of discharging those trauma patterns and orienting to a more regulated space.
Boy, that would be great. Self-care is very much on my mind all of the time, and I'll make myself a little vulnerable here and say that I've done this work for 26 years, but this year has been the hardest for me in that way. I can't really say why. There is a book, for those of you who don't know, called Palliative Touch Massage for People at the End of Life. There is an entire chapter in that book devoted to self-care. It's the second chapter. We knew better than to put that chapter at the end of the book. We knew it belonged at the beginning of the book. But I will share with you freely that I knew that I could not write that chapter by myself. I needed help because this topic is a struggle for me. So a lovely therapist, Rona Moore from Australia, helped write that chapter. I think it's a great chapter. And there are in that chapter rituals, something as simple as taking your name badge off. There's a bridge that I cross getting home from where I work, and I will take my name badge off and place it in my cup holder just as a signal to myself that my workday is done and I'm transitioning, to I think we constantly have to be looking for a lightness of being or a ballast to find balance in the heaviness of this work. I think we look for opportunities to laugh with our clients. Susan, wouldn't you say we laugh a surprising amount of
We
time?
do. We really do. Yes.
There's more humor in all of this, than you would think. People seem to need to find that even in the darkest of times. But Marcus, it's a great topic, and I think it's one that deserves
Exploring.
exactly. Yeah.
Yeah.
It's one of those areas that I'm working on, and I'm working with Dr. Price from the University of Washington for a touch therapy called mindful awareness and body oriented therapy that's taught to massage therapists. But as a emerging psychotherapist, I'm looking at bereavement and survivorship and sensory motor and somatic therapies that will help in this domain. So hopefully we'll be building out some resources for the Society for Oncology Massage and then offering it to all the therapists that are affiliated so we can begin the implementation of some of this stuff, because I see that as a gap in some of the care that we show up for everybody in the field, but I see a gap in the resources for showing up for each other.
Absolutely.
Completely agree. That would be fabulous. All right. Anything else?
Do you ever have people that you've already been working with and then you have to work with them at home? Do you make them fill out the new form, or do you transfer some of the information to the new form?
It would depend on whether if they're on hospice care or not. And what I mean by that is if you're working with an agency and they have vetted everything, there's no need to get permission from the patient if you're working with a hospice agency and they've already been vetted. So is that what you mean?
No, I mean, if I'm seeing somebody in my office here and I'm seeing them once a week and they're going into hospice and then they need to be seen
Okay.
at home, that shift from probably already palliative to hospice, do you fill out a new form?
No.
No.
What I would do, I don't like
Mhm.
making work for myself. I would probably just staple or clip
Mhm.
Or
Mhm.
if you have a file per client, just stick the new thing in because you will need some new information when you move into the home environment. You'll need to know who the primary caretaker is. That person
Mhm.
becomes the gatekeeper.
Yeah.
Eventually your client's not going to be answering the phone.
Mhm.
Eventually your client's going to be
Right.
sleeping a lot. So you need that primary caretaker. um, you need to know, well, you probably already know about comorbidities, but there may be some things on that
Yeah.
palliative care intake form that are a little bit different or new. I just wouldn't recopy everything that
Yeah.
you already
Yeah.
have.
So if you're working with a hospice agency, do you do and keep your own notes, or do you have to do notes and give to them at the end of each session?
Every agency is different on what they
Ah,
require. And I'll describe my current situation and I'll ask Cindy to share hers, and you can see how broad the differences are. I work for a contract with a small hospice agency in rural Arkansas. And the census of this particular agency is about 60 to 65 patients. And when I initially started with them in 2019, they required zero reporting. I kept my own notes, progress notes, and the time that I was there, all of those things I kept for my own records, but no one ever asked me for them until just like within the last 4 months. They're
mm,
now asking me to submit that information. So I'm now providing progress notes on what I did, the amount of time I spent with the patient, et cetera. And the initial information that I received from my agency is very, very basic, even less basic than what this intake form that we're providing asks.
mm.
And it's sent to me through email. And then I, of course, reach out to the primary caregiver and set that initial assessment up. So now I'd like for Cindy to share with you where she works and the difference there.
So I don't contract, I'm employed. I'm on the staff of the hospice where I work. So I have a work issued laptop. I have access to the patient's entire electronic medical record. It's an overwhelming amount of information, but I've learned to go through that chart, boom, 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 pick out what I know I need. And then the record keeping similarly is a little burdensome. I'm required by law to create a care plan, to document every visit, and there are boxes that I fill in with certain narratives, but we're required to complete that within 48 hours of seeing every client. It's a big part of my job.
Mhm. Yeah, that's wonderful. That especially that you guys are doing different things. Yeah.
We're on opposite spectrums, I think, doing the same type of work, but yeah.
Yeah. My hospice
Yeah.
is very large and it's
Mhm.
urban. It's here in Dallas. We have a census of 250, so compared to Susan's of 60. And I'm actually stationed in the inpatient unit where we see folks whose symptoms can't be managed in the home. But because I did field work for years and I love it, I actually volunteer to see a few patients in the home environment. So I'm kind of getting my cake and eating it too. I get to do both. We love our work. We know you all feel that way about your work, right?
How long are your sessions?
So, in our 20-hour class, we cover the stages of dying from early decline through late decline, pre-active, active dying, and the time of a session will correspond to those stages of dying. Someone during early decline who maybe has up until recently been driving to your office, and then you decide to see them at home. Maybe your office session had been an hour and you might be able to do an hour of massage, but likely it will be getting to be more like 45 minutes, 40 minutes. And then during late decline, it'll be more like 30 or 40 minutes. During active dying, our sessions can be as short as 10 or 15 minutes. So, really corresponds to the energy level of the client.
That's what I've noticed too. Is at Mayo Clinic we did 20 to 30 minutes with. I mean, we saw every department in the hospital, and we were doing inpatient care. But I noticed with home visits as they're moving into end of life, they tolerate less. I mean, they like it, but it can be a little bit overwhelming too. And so I've shortened it to 20 to 30 minutes for end of life.
I was going to say, Marcus, you might find that even if your touch session is only 20 or 30 minutes, you may end up being there longer because now all of a sudden you have caregivers in the mix and they have their own needs too, right? We could make a whole course out of if people come to your studio, you deal with one person, the one person on your table. But once you start going into the home of the environment, there's a whole cast of characters and I do the emphasis is on characters, it's a lovely, fun, colorful part of our jobs, but we often put as much energy and time into supporting those folks.
Yeah, that's for sure. And I think there's some education that needs to take place during that window of time. And there's plenty of dissociation and depersonalization that's happening in that space too, as they prepare for the loss of the person.
Some of you have been very quiet. Anybody else want to say anything?
Okay. Well, if you think of something, have a question pop up, please reach out to us. We always love hearing from others. And you can always just send us an email through our website, finaltouchtraining.com, as an easy way to reach out to us.
And you do your training live or you do it online?
We do both. We have
Okay.
a 20-hour live course, and I will be teaching twice in 2025, January and again in June. Both of those live courses are at the T. Boone Pickens Hospice Center where Cindy works. And it's a beautiful facility. Gives us lots of space. We get to take a tour of the facility. Cindy provides us with real life, up-to-date happenings as to what's going on at the unit. And yeah, it's a lovely space. So we'll be teaching in January and in June. Jen, do you have something?
Oh, I was just going to speak to that. I had the privilege of taking that training with Susan and Cindy in January. And yeah, it's a beautiful space and beautiful course and just such a great opportunity. Thank you.
Thank you. And then we have online 2 3-hour online courses. One is designed for caregivers, and the other is it's a very beginner course for massage therapists, which provides 3 hours NCBTMB approved course. Cindy and I are working on a third online course. And so there'll be more to come about that. It'll be another 3-hour course. And I'm actually in Dallas right now. I'm in Cindy's home. And we'll be working on that course more this coming weekend. So we're excited about that.
No,
Would
just
like
one
more.
thing, if I can speak a little bit. Sorry for my delay, but I thought that was in the right late in the night, and then when I saw on my telephone that the meeting was already going on, and then I say, okay, kids stay away, and then I go there. I'm sorry that I can't reach you in the first part of this meeting, but if I can share my experience here in Italy.
Yes.
Based on my
please.
own experience, but also on the book that Cindy talked about, The Final Touch. Because in Italy, when I started working in the hospice, I didn't have the same experience that I have acquired now. So for me, it was a thing that was new. And then step by step, I improve my own system. But all the organization that I work with required me to report all the time what was going on the patients. So every week I need to make a report for each patient and then give them to to the nurse and to the doctors, because sometimes it happens that the massage can help them with medicine, making medicine more effective, or also provide massage before giving them the medicine after 1, 2, 3 hours. And that is based on the experience that we have. We made some abstract for the Italian Congress of Palliative Care, and then we report our activity there. I don't know if it's possible to make that maybe international, sharing our experience, what's the experience you have in hospice in America and also here in Italy. But I think that is a good opportunity for all of us to share what happened in the palliative care with massage and aromatherapy, because I use also aromatherapy. And I think that also the chapter 2 that you described before about the book was very interesting and helped me a lot.
Good.
Especially, I used to put the hands out of the patient like a sort of a ritual that makes all the negative energy out of me, but also out of the patient. It happened also today that one woman said to me, I saw that all my negative energy were going away. And you were here, and you massage me, and then you give me this opportunity. And I think that is one of the best things that we can reach with our work. And all with this experience can be shared. I think that is very, very important for patients, to give them the opportunity to still stay alive, but also for us. So thank you.
Thank you. Thank you. And Marcus, we'll be eager to hear from you as to your work. That sounds very interesting.
Thank you. Yeah, I've been working on it for a few years now, and there is international psychotherapists that are doing body-oriented therapy and working with body dynamics in the Netherlands to do character analysis, which is a kind of neo-Reichian understanding of muscle tension based on developmental trauma. And it's outside of scope for massage therapists, but some of the muscle assessments are something that can be taught to massage therapists and actually implemented under the LMT status. And so the goal at this point is to design a system of pre and post assessment for bereavement, for survivorship, for family members who are dealing with grief and trauma, and then using other kinds of somatic therapies to then facilitate discharge of the grief trauma. So we'll see, but we do begin our first breast cancer survivorship research this winter.
Nice.
And so I hope it'll be a small pilot study, but it's being facilitated with MABT, and it's currently already funded by NIH and has plenty of research with different sectors of the trauma world, but this will be the first to be done in the cancer world. And so we'll see how it goes. And if it goes well and we get good results, we'll be presenting at the Healing Summit. And then from there, we'll expand into other sectors of oncology. And my hope is to also use this in family members and in vicarious trauma situations.
Very nice. Thank you. Okay. Are we done?
Yeah.
Anything else?
Yeah, Cindy, you and Susan are free to go. We really appreciate you. And I'm definitely going to be saying we need to have you at the summit. I shouldn't say that out loud, but I just did.
Well, thank
You
you
know,
very
One
much.
one nice thing about this work is we don't get attached to outcomes. So whatever will be, will be.
Yeah, it's a good thing. And I really love seeing everybody here today, but I want us all to wave to the people are not here, who are going to watch it later, because you don't know how many people actually do that. And we really appreciate SFOM for making that a reality and something that can happen, because as you all know, we can't all get to the meeting on time at the same time on this day and everything. And so it's beautiful that they can go back and watch these things later. And you may be hearing from some later that will watch it and say, oh, I've got a question. And
Sure.
so I know you guys welcome that. And Laura Ellingbo, did you get your hair did? Is that a new hair thing? It's cute. I just thought you got it done recently.
It's starting to grow out again, actually. I had it much shorter.
Okay.
Yeah.
So that's
it's-
growing out and being outside. Looks cute.
Yeah. Thanks.
Yeah. And Cheryl, do you have any announcements for anybody? Or we still need volunteers everywhere. You're
You're muted.
Mute. Yes, we do. I agree with you. And we've been blessed that we've had some really good people step up to the plate, and like Marcus join the board of directors. And we will be forming an advisory board as well for the organization. And one of the things we really want to continue to focus on is education. So we just restarted the group meetings for the Summit Planning Committee. And one of the things we're going to need for the virtual summit are people who are willing to volunteer to kind of facilitate that a little bit. So you might pick a topic that you would be there to send the speakers questions from, a list of people asking questions. You might facilitate a little Zoom room if you could. It's a good way to get your face out in front of people, let them know about the work we're all doing, and also what the Regional Champions is all about. So I'm going to really encourage Regional Champions. We're only going to have 4 breakout sessions at the virtual summit. So if we can get a few people that are willing to commit and contribute, that would be fabulous. So I will get that out to you shortly.
will actually teach us how to do that.
Yes, she is. Ashley has agreed to be our tech support, and we'll also be doing all of the recordings of the speakers and then coordinating the live portion of each event. And she'll also train all of the people on how to navigate the Q&A period that's going to follow each talk. We've identified some key pieces that we're going to talk about, and we're working on them right now, but things like clinical aromatherapy and how to integrate it into your practice, whether you're, in massage therapy, estheticians, end of life, whatever. We are also going to bring in somebody who does lymphatic surgeries to talk about lymphatic surgeries and how we can integrate our work within lymphatic surgeries. And the microsurgeries right now are fabulous. And I think, I went to school for massage a long time ago, and I never even thought about that. So this is, a whole new field for me. And so learning about it's going to be really interesting. We hope to then piggyback all of these speakers at the virtual summit into the in-person summit in 2026. So we'll have a broader discussion at that point. So you might find somebody you really want to hear more from at the virtual summit.
Terrific.
So super excited about a lot of things happening.
Mm-hmm. Well,
Do we have
it's
a
so
date
good.
for the virtual summit?
What's that?
Do we have a date for the virtual summit?
We do. We are publishing that, but I'll just tell you it's in May of next year.
Okay.
Okay. It's May. We had it originally in February, but we had a lot of not grumbling, but requests to consider people's holiday seasons and how busy they would be over the holiday season to get something launched for February. So we're moving it back to May to honor those requests. And then the next year will be still in April. and we're still going to be in Minneapolis at the Northwestern Health Sciences Center. We do hope at some point to diversify the in-person so that we can travel around the country so people don't always have to come to Minneapolis. Maybe we could be in your neck of the woods, whether it be somewhere like Dallas, San Francisco, whatever. Even up in Canada, we're open to that. So whatever would work. Again, just to diversify and let other people have an opportunity to come that maybe can't travel that far. And eventually, who knows? I hope to do some international work. We have an awfully big international group. Danielle is a part of that in Italy. But we also have people in South America, Australia, South Africa, Hong Kong, all over the place now. And it's super exciting. If you ever go on the website and click on Find a Therapist, you'll see a map pop up with all of the dots on it now. And it's really cool to see how many people are in there.
Mm-hmm. Yeah. How are you doing, Jen?
Doing good. Yeah. I personally don't do a lot of end of life stuff right now. I've kind of been in touch with the hospitals and stuff, but a lot of terminal diagnosed clients that are still able to come to me. So yeah, those sessions are looking a little bit shorter for some of them, but all this information is still utilized a lot, even in my own clinic practice as well. So hopefully with time and as my schedule changes, the hospitals will reach out a little bit more and be a little bit more open and receptive to that in this area.
Good. And Laura, how are you doing? Oh, you're muted. That's how you're doing. Laura, can you hear me? You're muted.
Oh, I'm so sorry. There we go. Is that better?
Yeah.
Oh, okay. So I am actually expanding my practice. So I'm going from just myself for the last 9 years, and I hopefully will be open September 3rd. And maybe diving into the employee part of the business. But I'm off all month of August, so I can really focus on all of this. Yeah, so it's going good. It's a little scary.
That's a big deal.
It is.
Congratulations.
Yeah,
That's
thanks.
wonderful.
So if anybody knows of any massage therapists that want to come to Wisconsin, I'm hiring. Yeah.
Wisconsin's fun.
Yes. We have lots of beer and cheese. It's perfect. What more
Yeah.
could you want, right?
Yeah. I mean,
Yeah.
I've only been to Milwaukee though,
Okay.
but I have a friend that used to bring me apples,
Okay.
and
Sure.
she swore they had the best apples in the whole
We have
United
a lot of
States.
orchards. Yeah.
You don't hear that. You hear beer and cheese,
Right.
but they were amazing.
Huh?
Yeah.
And a lot of wineries
Mm-hmm.
around here.
Yeah.
We're just
That's
an hour and
great.
a half east of Minneapolis. So
Mm-hmm.
yeah.
Yeah. And Marcus, big changes for you? Or are there changes you'd like to report besides this board position, which is
Well, thank you. There's a emerging feature in psychotherapy that's interestingly connected to cancer. So I met with the director of this program called Central Iowa Trauma Recovery. And she used to be on the board of the Iowa Cancer Consortium and actually came up with the idea of the integrative medical model that we use at the Richard Deming Cancer Center. And she's looking to take that and apply it now so she works with the federal government and facilitates funding for services for victims of homicide and victims of violence. And so I'll be onboarding with them and helping facilitate the somatic therapeutic resources in the similar way that we're doing with S4OM. So studying trauma patterns, looking at professional advocacy, learning to do therapy for the therapists to start discharging the accumulation of vicarious trauma. And that's kind of cool because we're bypassing the insurance industry and the typical kind of bill backs that you would do in mental health, because we're funded by the feds and we've got a certain level of privacy that's even above and beyond HIPAA, called VOCA. And so that's going to be a really interesting thing, and I'm going to love to see how that helps to inform the work that we'll be implementing at S4On for the more somatic and body oriented therapies.
Lovely. And Daniela, how are you doing?
Yes, I'm focused on hospice work, but Cindy, no, I'm writing a book also about the experience that I have in hospice with the stories of the patients that needs to be recognized as the same they are. And I'm planning also to teach the nurse and the sanitary, how can I say, people that comes to the hospice about touch massage and final touch in the next few months.
Nice.
So a lot of things makes me happy, but also tough thing that makes me alive.
Yeah.
That I contribute also to spread the word of the society here in Italy. Yeah.
Very good. And Miss Cheryl, check in. I don't have your sound. You're muted, Cheryl.
I
There we
said,
go.
I'm retired, so I'm good. I worked in oncology massage for almost 30 years, and now I work to support the Society for Oncology Massage and Aesthetics, and I really am glad to be doing it. And I love hearing what everybody's doing now, because part of me deeply misses it, but part of me is deeply grateful for the opportunity to step back and just bear witness.
Mm-hmm. We really appreciate you. You're back there. It's like you're juggling all these invisible kittens for us. And we
not really invisible, but yeah, they're real.
They're real. But thank you all so much for being here today. And definitely feel free to reach out to me, Cheryl, even Marcus now as a board member. If you have any questions or concerns with S4OM, you can also always reach out to Ashley. She's not there, but she's there. And remember to get in touch with Susan and Cindy if you've got any questions. And maybe we'll see one or two of us at least at the next final touch class. You never know. Thank you all for being here. And please have a great rest of the week and weekend, and just do at least one really good thing for yourself because you deserve it.
Thank you, Zerla.
Thank
Bye-bye.
you.
Thank
Thank
you.
you.
Take care, all.